Good afternoon everyone, I am Dr. Bhanu, working as a consultant minimal access surgeon in Imperial Hospital. So today's topic for discussion is acute abdomen. Mainly it's regarding radiological observations in acute abdomen, which we named it as CT pearls. I am going to give the discussion on the following slides. Can I remove that? Okay, yeah, today's discussion will be based on these headlines: acute abdomen, especially to rule out the emergency. And common abdominal emergencies. What are the most common abdominal emergencies that we see in ICU or when a patient comes to casualty? And importance of CECT in that setting of emergency, and what are the CT pearls which help in recognizing that it is an emergency so that the patient can go to OT or any intervention as soon as possible. And conclusion. So coming to the first slide, it's important to recognize which is an emergency. So especially for surgeons, time is an issue to decide the prognosis. So when the patient comes to casualty, or when we get a referral for a patient in ICU setup or something, these are the signs which let us know that, okay, this patient needs emergency care and you need to address something which is going very wrong, and time is very important in that situation. So these are the warning signs for abdomen examination. Usually it's common for most of the emergencies. Unstable vital signs, even in neuro case, vital signs are critical. So specific to abdomen, peritonitis, or any concern that the abdominal pain is life threatening. Most commonly the condition is mesenteric ischemia, which we often miss or overlook, and at the same time perforation, which is an age-old common emergency. And MI, obviously we all know that most patients, they can't attribute the pain whether it's to abdomen or chest, which is retrosternal. So it's important to rule out MI even if the patient says it's abdominal pain. Before attempting some kind of major interventions like a CECT abdomen or MRI, it's important that we get a basic ECG and rule out MI. So most common differential diagnosis for abdominal emergencies are aortic aneurysm, mesenteric ischemia, perforation, bowel obstruction, volvulus, ectopic pregnancy, and you can see myocardial infarction and splenic rupture. So what I feel is, most of the time if you ask certain basic questions like amenorrhea, simple, when a patient comes to emergency, 18-year-old woman saying, I'm having severe pain since last night, rather than shifting the patient immediately to CT, one simple question of amenorrhea will stop a catastrophe like doing a CT scan for that pregnant woman. So simple questions like amenorrhea or even vaginal bleed will help in ruling out certain these emergencies. Like in the same way, myocardial infarction, if you ask he has got any breathlessness issue, you can simply get an ECG before running to CECT. The same way, perforation, like patients, they usually have chronic gastric issue, so those are the patients which go for perforation. So simple questions will let us know the next following step. So what is the role of CT in this emergency setting? So it's being clearly displayed. Most of the time you can come to the conclusion just by history and examination. Like I said, like perforation, you can ask if he is having gastritis issues since few years. The same way for obstruction, if you ask if he had undergone any surgery, that one question alone will let us know, okay, maybe he is having adhesions, so he has developed obstruction. So simple questions will give us diagnosis in 76% of the cases, but in other 25% CT scan will help. But the role of CT mainly is how to approach the patient. Does he need the surgery or ICU management in terms of putting a drain or CBD exploration, ERCP, or in case of aortic aneurysm, CT angiography, what is the next step? This will act as a guideline. So that is the importance of CT. So the next question is, does he really need the IV contrast or without IV contrast? I really believe this is the most important question. Even if you ask for a CT scan, question is, does he needs an IV? In emergency setting, let's say I was told an example, I did a hemorrhoidectomy, I think in last 2 months back, patient came for grade 2 hemorrhoid saying I need a surgery. So I asked, you don't need the surgery. He came from somewhere from Rajahmundry. So I told, you don't need the surgery. Then he told, an 18-year-old female died of after undergoing evaluation for CT. So when I asked the question, what they told is, as she is female, she didn't tell their parents that she is suffering from hemorrhagic hematochezia. She is losing some blood in the stools for the past like 5 days. So patient fell very ill and they took her to local casualty. So, so casualty doctor, whoever was there, okay, bleeding is there, we'll get a CT to get the diagnosis. So they got the CT scan. By next day, overnight, patient, the way the patient explained, attender explained is, patient died of throwing some vomiting some froth outside. So the conclusion is, what was happened in that case is, so without resuscitating the patient, they have the CMO thought that okay, will come, diagnosis is important, so let's get an IV contrast, and they send the patient without giving IV fluids. What happened there was, so patient is grossly dehydrated since 4 days, HB must be 3 or 4, without giving IV fluids or seeing the urine output, they rushed into IV contrast, patient died of, and after giving IV contrast, then they gave the IV fluids, so patient developed pulmonary edema. Diagnosis has come, but the patient is not there to see it. So I feel IV contrast has got a significant question. Simple catheterization before asking IV contrast and see output to decide whether the patient needs or IV contrast. Diagnosis doesn't matter if urine output is not there. So that's one significant point. And oral or rectal contrast, it mainly helps for GI surgeons, for medical gastroenterologists mainly to decide if there is a perforation, location of the perforation, and in case of ischemia and intussusception. We all know, like we have main 3 modalities of investigations for GI: USG, CT abdomen and MRI. In USG we always say in terms of hypoechogenicity. Echogenicity is the word which we tell to come to the conclusion. The same way in CT, these terminologies will be used in the next slides, like attenuation, density and enhancement. When you give the contrast, and how we describe in CT scans is, how is it enhancing? If the blood supply is good enough, we tell it's well enhanced, or else hypo enhancement. So this is the terminology. And in MRI we all know it's hyper intense. Yeah. So this is the slide which my boss told me when I was in Apollo. So I was a mediocre in studies, so he always used to tell, see, if you don't know what you are looking for, you will never find. So inference of this slide is, so before asking for a CT scan, we should have an idea why we are asking. Are you looking for an obstruction? Are you looking for a perforation? Or are you looking for an aortic aneurysm? Whatever it is, before asking for CT, as I have put the differential diagnosis, you should go with a clear-cut mind, okay, the anomaly is in the upper abdomen or in the lower abdomen, or it is an obstruction, or let's say the patient, simple question like, if the patient is having heart failure and he came with a pain abdomen, then most often what we think in terms of is because of the failure, there are some gray areas in the bowel, what we call it mesenteric ischemic colitis. There are some gray areas in the bowel. So if the patient is having cardiac failure and he came with a complaint of diffuse abdominal pain, then we'll think of ischemic bowel. So that is an emergency. So that's how we have to ask yourself questions before asking CT. So today, as you know, CT is a vast topic. I'll just describe about these four things. Air, which is like, for surgeons, there is this thing for surgeons and any medical gastroenterologists, in society there is a misconception about flatus, but for us flatus is a dream. After the surgery, if the patient passes flatus, we all say, happy, you can go home. And even orthopedicians will relate. So in this CT, air is a bad thing. So what I am trying to convey is, so air in the abnormal region, let's say if the patient is not passing flatus, it must have been collected somewhere else. That's a bad thing. So if you see CT abdomen air, you should always be very careful. And aneurysm, it's not my topic, but it's an emergency which you can't postpone. That's why I'm discussing about aneurysm, but I won't go in detail about it. And obstruction, small bowel or large bowel. In obstruction, if there is compromised vascularity, what we use the term is strangulation, you know. And closed loop obstruction, this is also an emergency. Closed loop obstruction and volvulus, as you know, it's more or less the same term, but closed loop obstruction can happen in terms of if the patient has a hernia, something just popped out of the abdominal cavity, that can develop a closed loop obstruction. So hernias can also cause closed loop obstruction. And ischemia, ischemia, it can be from small bowel or it can be from the colon, ischemic colitis. The cause can be arterial or venous, and the same way it could be due to simple thrombus or an embolus. But most common cause of ischemia to the bowel is because of the embolus. We always say, like, the patient has got, like I said, simple question of is, does he having any valvular heart disease, rheumatic heart disease? That question, patient comes with abdominal pain, you can think of embolus. Then you can ask after CT, if there is abdominal pain, if you still have doubt, you can ask for CT angio, that gives you the answer. So most important thing is examination won't bypass any other, it's not an excuse. Starting with the simple perforation, all of this is a quite a common thing, and but the problem is you can sometimes miss air under diaphragm. This is the most common term used, in people who are working in emergency. That's the first thing you look in an X-ray, but it's not always found. It's not because of unable to read or something, but if there is small gas, if it's a small duodenal perf, we have one patient with the posterior wall duodenal perf, there won't be gas in the diaphragm. So it's always, CT will help in finding out even small amount of hair. Same way, like in the picture it's being, so you can see this is the gallbladder. There is gas around the gallbladder. You can see the gas in here. This is the typical gas under diaphragm. But is it because of the perforation of the gallbladder or something else? In this case, you can see in CT, the simple way of seeing things, or how I remember, is you can't see in dark. Air you can't see. So that's how I remember. Air means black color. So anything that is black, that is air. So in this picture, this is the air in the stomach, and this is the gas under diaphragm. So the same way you can see around the gallbladder there is some air, but is it the cause? We don't know. So this patient will need an oral contrast to see if there is any contrast leak. You can see in here this small opening, if you see it in the next slides you will appreciate better, but this slide is just to let you know this is how the gas under diaphragm looks even when it is minute amount. And coming to the next slide, you can see going by the laws of physics, if you are defying gravity, something bad should be there. So the importance of that comment comes in the next slides, but in this you can see air, it always settles up. So you always look in the anterior part if there is any air under the abdominal wall. In this case there is air under, you can see in here, you can see, next slide. So importance of CT comes in, even X-ray is more than enough to find out the gas under diaphragm in most of the cases, unless it's very small, sealed off perforation. But CT, the main role comes in locating the site of the perforation. Not always, but it at least guides. Okay, when surgeon is going, he had to do the upper midline or lower midline incision rather than cutting from up to down. So the same way in this you can see gas under diaphragm. But where is the location? Here you can see this is the IVC. Like I said, the terminology is in this you can see aorta. There is no enhancement, so there is no IV contrast. You can tell, like, the density within blood is equal to the liver because it's highly vascular organ. But there is something black in here, so it's an abnormal air and it is defying gravity. So that is very wrong. So air in the abnormal area without floating up is also wrong, but if it is in the abnormal area, is something very wrong. So this is IVC, there is air around IVC. So IVC is a retroperitoneal organ. So if there is air in the retroperitoneum, we think of duodenal perforation, because duodenum, certain parts like second part, third part is in the retroperitoneum. And in the same way, this is showing the site of the perforation. If you can see, this is hypodense. This is fully black. This is grayish black. This is a bit darker. So I know it's quite difficult to point out whether it's the site of the perforation or not. But this is the area where the questions will give you the answers rather than looking for small differences in gray shades. So if simple question of a patient is having PPAs for longer, that kind of questions will give you the answer. Simple question like does he have typhoid before? Then you can't find a perforation here. You often suspect those perforations in ileum. So oral contrast, the role again, is it really needed? Let's say a patient of aneurysm has come, patient has come with severe abdominal pain, vitals are not being maintained. If you think about asking for oral contrast, they'll take 2 hours more. You'll get a report, but the patient will not reach the ICU also. So point is, if you're thinking again the question, is it an abdominal bowel cause? If you're thinking in terms of perforation, adhesion or like strangulation, then you give the oral contrast because it takes much more longer because emptying time is quite long. So this case, you can see this is the duodenum. Here the word is not enhancement, the contrast is there. So contrast is leaking outside the bowel wall. So this way we can identify the location, the cause of the perforation and location of it. So in this case you can see air is floating, there is oral contrast, you can see the stomach with the contrast, this is aorta, there is no contrast. So IV contrast, maybe it's a delayed film. So you can see in here, like all around the black there is whitish color. That is nothing but the contrast. But you can say, there are some rare things like, Chilaiditi sign or something. It can be colon, you're just bluffing. The point is you have not given oral contrast. So if you are saying contrast, you have not given IV contrast. So it's not an enhancement of the wall, and still the contrast is outside the lumen. So that indicates there is a perforation, and it is in the lesser sac. So we think more of in terms of gastric perforation. This is a gastric perf. Coming to next slide, aneurysm. This is just overall idea. I'm not going to detail, not my area of expertise. So this, you can see, this is an abnormal size of the aorta, and there are common signs by which we can identify the aorta. The reason why I'm putting this is you can't wait for the radiology expert in these kind of situations where time is life. In this case, there are few signs called draped aorta sign. In this you can see this is aorta without IV contrast, this is with IV contrast. The reason why it's important is, you can see the contrast is not coming out. So it's a ruptured aortic aneurysm, but it is contained. There is no active leak of the contrast. The same other significant signs to identify aneurysms are retroperitoneal hematoma. So you see this is the kidney which is hyper enhancing. So right next to it, it's a retroperitoneal organ. So if there is something darker than air, it should be blood. Or there is something ascites also, but it is more enhancing. A simple way to tell it's blood or water is it's all relative in CT scans. So see the liver. If it is of the same size of color of the liver, it should be blood, because liver is very vascular organ. If it is lighter than liver, you can think it can be simple ascites. Yeah. Going to the next slide, this is something, this is again, this is the one which saves the life. So impending rupture, so you can see in this, they have not given the oral contrast because it's not enhancing. The same way, this can be it's more of aneurysm which is about to rupture. You can see there is no retroperitoneal hematoma. So it's just an impending rupture but not ruptured yet. So if you see retroperitoneal hematoma, that means it is already ruptured, but in this case you can see this is a descending aorta, right and left common iliacs, and there is well demarcated blood. So again it is a contained rupture, but there is no active extravasation. In this case you can see this is the contrast they have given, which is not coming out when you have done the CT. So that means there is no active extravasation, but it already ruptured because there is huge retroperitoneal hematoma. Yellow arrow indicates retroperitoneal hematoma, and this is probably the site of rupture. So in this, the importance of this slide is, when you give I know CT scan is not an ideal investigation to identify the location. CT angio helps in case of aortic aneurysms, even to do some intervention also. So this is aorta. You can see something abnormal trickling down. So this is active extravasation. This helps us in to understand the next line of action. So it's important to identify these small signs. Coming to the next slide, topic is ischemia. This is one of the most common abdominal emergency which is often missed. The reason is most often patients also, even normal patients, they tend to overact most of the time. But ischemia patients are the ones who which feed on overaction. My point of what I am trying to convey is So signs out of patient looks like more of neurogenic, I mean neurotic. I mean what they say is when you touch the patient is absolutely, abdomen is normal, there are no signs of peritonitis, abdomen can be soft, but the patient says I can't tolerate the pain at all, and he jumps in and in and out of the bed. That kind of typical feature, first thing you have to rule out other than giving it to psychiatry is mesenteric ischemia. It's because something is dying inside, body won't let it die. So the patient expresses in terms of pain. So there is some term for it to say the pain is out of normal. So the patient keeps jumping. If you see that kind of a patient, you have to think about ischemia. So this simple X-ray will help, but X-ray is not an ideal investigation because you can miss unless it is very late. So this is something called thumbprint sign. You can see when you give the contrast as if someone has put a thumb on a black paper. You can see this is a thumbprint sign. So ischemic bowel, how do you identify in CT? In CT scans, importance is again the same thing. You can actually wait for 6 to 8 hours until the radiologist comes and reports. The reason why I'm discussing ischemic bowel in this one is you can't wait for the report. You have to intervene, or there's something called in perforation there's something called operate before sunrise or sunset. There is no something called next day. The same way in ischemic bowel, you have to go in as early as possible before your patient ends up losing the bowel. So these are the important signs. Most important one I feel is portal venous gas, because it can be easily picked, and when you see there is no second question, go in. So when you see this, you can contact the surgeon immediately, and you can only prepare the OT. And the same way, one more important thing is, like I said, double halo sign, target sign, and pneumatosis intestinalis. I think these three are the most important signs, which I am going to display in next slides. You can see portal venous gas. Like I said, anything air coming out is a good thing. When it is in the abdominal cavity, in the abnormal area, it should be very bad. Patient, So you can see this. It's more of a crow feet appearance. And the reason why I said peripheral is, let's say patient has undergone a surgery, or patient has undergone CBD cannulation, then there is gas again in the biliary radicals, but not in the portal venous system. When you see in the portal venous phase, if there is gas in the liver, especially with this appearance, that means something wrong. The reason why the gas is there is, let's say like there is some small bowel ischemia. When there is death of the bowel, the bacteria will degrade and produce gas. That through the veins, it goes to the mesenteric vein, then enters the portal vein and ends up in the liver. Because of the gravity again, or usually gas collects in the peripheral areas. So this is one thing. And let's say there is CBD cannulation, then you can see, but the gas is in the CBDs. That is irrelevant now. But this is one of the most important, and you can easily identify the sign. So please don't miss. And one more important thing is pneumatosis intestinalis. This is again, like I said, air in the abnormal area. We know the gas is there in the bowel lumen, but when it is there in the wall, that is called as pneumatosis intestinalis. So you can see this is cecum. They have given the contrast, so you can see the enhancement. So it's obeying the laws of gravity. Gas is above because it's lightweight. It is staying up, but you can see small spicules of gas in here. So this is not following the laws of gravity, so it's abnormal. So the condition is pneumatosis intestinalis. Here you can see this is large bowel. You can see the gas is there within the lumen, but it is nicely staying afloat. But you can see in here along the wall in the edges. So this is a typical sign of ischemic bowel. So there is something compromised in the blood supply, maybe because of the venous ischemia or venous thrombus or whatever it is. Cause doesn't matter as long as you can pick up something is very wrong. So in the next slide you can see, this is a bit difficult to identify. The same thing. You can see black color, small here, the white arrow is showing all along you can see. So simple question, this gas is floating, air is floating, this is not. So that means something is abnormal. Then you can think of wrong things. So next thing is changes in the mesentery and the bowel wall. The reason why it's important is, like I said previous slide, you have seen the gas, but if you have seen the gas, that means it's already dead. Yeah. But in this case, when the bowel is still alive, there are certain features which will help in identifying the the next bad thing. So these are the small findings which will help you, but these are a bit difficult to identify. In this, you can see in this slide the arrows it is showing. You can see this part of the bowel, this is normal. So one line of white thing is there around, that is enhancement of the normal bowel wall, and this is the gas. So you can see in this bowel, you can see different colors of grey color. So that is abnormal, and there is no gas, it's completely collapsed. So in this case, the description is, you can see mural enhancement is lost. That is a terminology to say there is ischemia. So normal contrast is not entering, and the wall is, certain layers of the bowel wall is hyperemic and certain wall is less enhancing. So that's an abnormality. In this slide you can see more clearly, so there is contrast, but there is a collapsed lumen with air. But you can see this bowel loop, how the white line is very narrow, but in this you can see how thick it is. That indicates submucosal edema. Submucosal edema, only way it happens is when there is a ischemia or gross inflammation. So any abnormal thickness of the bowel wall is very significant. In this case you can see here they have mentioned about fluids, and there's something called mesentery which has got fat stranding. So fat is always black, like I said. So when that fat is as if someone has scraped on it, if it looks like that, that is called fat stranding. That is one of the signs by which you can tell there is an infection or inflammation, sorry. So yeah, the previous slide it's difficult to pick. I do understand it's quite difficult to pick up what is an inflamed bowel, or bowel loop, is it, how inflamed is it, is it going to ischemia. But this slide, this is where the importance comes. Simple, this is one of the typical signs of ischemia. You can see they have given the oral contrast. I'll compare. Okay, you can see this bowel loop. So how the wall is, one nice white line is there and the gas is there. That's how the normal bowel should look. But in this case you can see this is the contrast and how big the blackish thing is. So it is not enhancing, that is called hypo enhancement of the bowel wall. This is typical feature of, the reason why it formed is because of the submucosal edema. That is one typical sign to say that it is going for ischemia. So double halo sign is one of the pathognomic features of ischemic bowel, and in this way that is where the role of oral contrast comes. You can see in this bowel you can't appreciate much because there is no contrast. You don't know how which is the thickness of the wall and which is the normal bowel wall, but in this it gives you the perspective. So lumen is this much, wall is this much, so that is an abnormality. Normal wall is like this. When there is submucosal submucosal edema, that's how it sets in. It looks like a donut, so it's called as double halo sign. So coming to the next topic, obstruction. Again, the reason why obstruction is an important one is not all obstructions, let's say post-op ileus, like post-op adhesions, you can always wait for 36 to 48 hours before you intervene something. You can always approach conservative. But these conditions, mainly closed loop obstruction, volvulus, intussusception, this will lead to ischemia, where the time is a constraint. So I'll tell about closed loop obstruction. These are the signs. Typically you can remember U or C shaped loop, oval sign and beak sign, which I am going to display. So in closed loop obstruction, simplest way to identify is you will see one grossly dilated bowel loop. So you can see in this, rest all bowel loops are collapsed, or you can't see anything significant, but something is popping out in here. This and like I said, fat stranding. What is fat stranding? You can see fat is always black, but the black thing is covered by something homogeneous to the liver, this one. So there is hyper enhancement of the mesentery, that is nothing but mesenteric fat stranding. So that feature, along with the one significantly dilated C shaped or whatever the shape, it is grossly dilated, one single loop if you see, that's abnormal. That is one of the signs of the closed loop obstruction. Like I said, volvulus is nothing but rotation of the bowel, one segment of the bowel. So these are the X-ray findings. Actually volvulus is one of the easy things to pick up because something very abnormal will be on your face. So this, you can see the first slide is, this is cecal volvulus. you can see something called C-shaped loop of the bowel. It can be whatever, cecum, yeah, like I said, you don't have to pinpoint what exactly is the diagnosis, but if you can understand if that is wrong, then yeah, things can be done. So like I said, this is a C-shaped cecum, and this is also cecum. The reason why it is other way around is there are two types of torsion in cecum. This is axial, this is yeah, transverse axis, it gets rotated on. So this is also cecal torsion. But yeah, for surgeons it is important to understand whether it is cecal torsion or sigmoid, because yeah, again the incision depends and you have to tell the patient attender whether it's an ileostomy or a colostomy. So in this case, how do I say is, let's say this is a mesentery. So mesentery, if it is to the in this, I can tell like this, yeah, this is sigmoid volvulus. You can see the mesentery is to the left of the spine. So it is sigmoid volvulus. More easy way of saying is, if the bowel loop is more towards the right upper quadrant, it's sigmoid volvulus. If it is more towards the left upper quadrant, it is cecal volvulus. That's a simple way of putting it. So yeah, these are the important signs. If you see in the CT cuts, one abnormally dilated loop, there are different shapes of it. Most common shapes are U and inverted U. You can see this is an inverted U loop, huge inverted U loop, and this is a inverted C-shaped loop. But most important thing is you have to see how the mesentery is. Mesentery, you can see the fat along with it is hyper enhancing. That indicates there is some engorgement. Engorgement is because of twisting in the mesentery. And like I said, there is one more important sign called beak. I think I'll show it in the next slides. But like I said, when you go through the CT cuts, if there is one abnormal enhancement of the bowel wall and one big loop, that indicates there is something very wrong, which is usually closed loop obstruction. In this you can see, note the mural thickening at the transition zone. So there is something called transition zone in obstructions, which is where the culprit is. I mean, there are previously grossly dilated bowel loops and there is collapsed loop. The area of transition is nothing but the transition point. So that is the usual culprit, which is the cause for obstruction. So it's important to identify in CT those things. So this is the beak sign. Here you can see this can be the head and the beak is peeking out. It's not easy to identify these things in a routine way. I think even these people must have struggled for 30 minutes to pick this slide. So it's not practical to identify these beak signs and all, but you can't miss this big loop. So if you can identify that, then I think yeah, work is done. So in this case you can see again there's something called whorl sign. Like I said, when you give an IV contrast, usually mesentery should be with the fat. So it should not be this grayish, fat should be something like, this is air. So it's lighter black than this, something like this. But this is getting hyper enhanced. That is because of the congestion. So that indicates the mesentery is something wrong is happening with the mesentery. Most commonly it is twisting of the mesentery, which is called as whorl sign. So if you identify something twisting whorl sign, it indicates this volvulus. It could be midgut volvulus, cecum. Again, the cause doesn't matter when you can identify the abnormality. Whorl sign you can see in this. So oral contrast is given. You can see as if some tornado is there. This is called as whorl sign. So it is nothing but what indicates is there is twist in the mesentery. So you have to go and untwist it. There is no other way of giving a pan or PC to correct it. So he needs, it's a surgical emergency. So that's the importance of this whorl sign. So again, strangulation. In case of obstruction, like I said, like let's say patient had undergone surgery 2 years back and he came with obstruction, which is he's throwing, vomiting, not passing flatus. You can wait for 2-3 days and repeat a CT scan. Then when you see these features, like I said, you can see this is the area where there is some fluid collection. So again, the fluid is in abnormal side. It is outside the lumen. So it could be ascitic fluid or free fluid. So the reason why the fluid is, it's because of the exudate, or it's not, sorry, it's a transudate. So that indicates something wrong is happening. So look at the free fluid and then look for other abnormalities as you have found something is wrong. So this is H, the one which is mentioned is, this is nothing but if you see more and more, then I think maybe it's easy to pick. But in this slide you can see this is nothing but hemorrhagic effusion. Why I am saying this is blood and this is fluid is, this is more enhancing. If you compare it with again with the liver or any solid organ, it is of the same color, so it should be blood. So if you are seeing blood outside, that means it's because the vascularity is compromised, there is some twist. So there should be some way to get it out. The body will tolerate only certain amount of edema. After that it will give just throw out the fluid. So if there is blood in the abdominal cavity in a patient with obstruction, that means he is going for strangulation and it is time to intervene. So again this is one typical sign, target sign. I think I will tell you in the next coming slides. Intussusception. This is again the significance of intussusception is, this is also an emergency. If you intervene, you can improve the prognosis very well. So what is intussusception? Yeah, as you all know, intussusception is nothing but one part of the loop entering into the distal part of the loop. So the proximal one, which is called the recipient is called intussuscipiens, and the loop which is going into the other loop is called susceptum. Here it is actually more common in the kids, but in elderly people with some leading point. What is called as a leading point is, let's say there is some lipoma, or let's say there is some tumor. It will pull the bowel into the distal part of the bowel and give what is called as intussusception. In this case you can see this is called typical target sign. Here you can see this is contrast definitely, because you can see in the bowel loop it's of the same color, and again after that you can see this some blackish, this is the one that is showing black arrow is air. So this is air in the lumen, that is okay. Again you can see various shades of grayness in one area, that means something very wrong is there. Most common thing that gives that kinds of different types of shades of grey is intussusception, because you can say to put in a more sophisticated way, you can see this is the mesentery. Mesentery has got a fat in it. This is the air in the lumen, but this is not the air. How do you identify? Is it's again enhancing a bit, not completely black. So that is why we tell it's mesentery. And this part of the bowel, like I said previously, you can see this is a normal bowel where the wall you can't even see because of the contrast. In this case, from here to here is again a donut. You can see this from here to here, it's nothing but the bowel wall edema. It is of the suscipiens, mean the recipient bowel is so grossly inflamed and there is compromised vascularity. And in the same way, in this you can see, like you can see all different shades of grey, like black color, then light grey, dark grey. As it go out, again outer wall is hyperemic. So usually this is less grey, the terminology is less hypoenhancement. Hypoenhancement you will usually see in the inside one, because that is the one which goes for compromised vascularity. So this is one typical, if you see donuts, it could be ischemia. The cause again, it could be different things. In this case it's intussusception. So target sign, that's one typical sign. In this you can see again, if you see some different shades of grey in one area circle, it's more it indicates something wrong. Again you should always relate it to the abdominal findings. How do the intussusception patient usually complains is he says he's throwing out, abdomen will be distended, and he'll have 1 or 2 episodes of bleeding per rectum. The stool is maybe black color or blood tinged stools. That means we think of intussusception. Like I said, you should always question yourself what you are looking, then you might find. So the next question is, next thing is target sign. Like I mentioned, in this case the previous X-ray, this is also target sign with oral contrast. This is without oral contrast, but in this case you can see the significance of this slide is it's nothing but fat. You can see in here this is fat and this is abdominal wall fat. Both are of the same attenuation. So it's abnormal. The fat is there in the lumen. It's nothing but a colonic lipoma which acted as a leading point to give the intussusception. This is the intussusception part, because you can see all shades of grey. So next comes adhesions. This is one of the most common causes of obstruction, but more often than not it's not an emergency. You can always wait for 24 to 36 hours as long as it's maintaining hemodynamically. So we have time for this. So in this case you always ask for an oral contrast because it's not a surgical emergency. So when you give the oral contrast, one typical sign to say that something is, some obstruction is there is this thing. It's nothing but feces sign. So feces is one, feces we all know it's a part of the colon. A large bowel is always peripherally located, to put it in a simple way. So if the feces is there within the center of the abdomen, so that's abnormal again, air in the abnormal place. So if there is feces in the small bowel, that means there is something stagnant there for long which caused bacteria to proliferate and produce some gas. So this is nothing but feces sign. If you see this, that indicates, yeah, you have waited in, not always, but yeah, there is obstruction which needs some intervention. So feces sign, this is important. And there's something called as bird beak appearance and all. So like I said, any obstruction will have transition zone, which is proximally grossly dilated bowel loops, and there is some collapse of the bowel. Beyond this level you can't see this bowel. Contrast is nicely coming, flowing till here, but here it disappeared. So that indicates that is the transition point. Basing most often it could be some small band or adhesion to the previous surgical site, that way. So here again you can see the contrast, the size of this loop, and suddenly it's getting collapsed. This is one typical sign of obstruction. Like I said, transition zone is nothing but area of collapse. You can see the significance of this feces sign is actually just before the transition point. That's where you often find the feces. So even if you don't find a beak, you find the feces. Usually that's where that part, let's say, how will I say it's the obstruction is at the proximal jejunal level or at the ileum level. If I see it at the feces sign with the ileal volvulae convoluentis, which is striae, we can tell it's an ileal obstruction. So that is the significance of locating the feces sign. And then you can see in this like typical bird beak appearance. And like I said again, if you see this stranding as if one black area is scratched, if you see that, that is nothing but fat stranding, that indicates inflammation. So inflammation in the mesentery, there should be some something abnormal with the bowel. Again, in this case you can see it's not a typical beak sign, but you can see the transition zone. So bowel lumen has got some contents, suddenly it's collapsing. In this case they have given the oral contrast. The significance is you can find the reason. Here you can, this is more of a stricture. Yeah, again the cause doesn't matter as long as you can find that it's an emergency or it needs intervention or not. So this is again, like I said, small bowel obstruction with ischemia. Let's say I have seen this and went to bed thinking it's okay, it will get better. Next day if you see this thing, at least then we have to realize and go in. I mean you have to intervene. Here the typical donut sign, again the target sign, the name doesn't matter. Point is you can see to put it in a way, you can see first of all feces sign is there, so there is an obstruction. So next thing is we have to find if the bowel wall is it alive or dead. How do you find? There will be typical submucosal edema, like I said. Here the different walls are enhanced. Here you see this is the air within the lumen of the bowel. This is nothing but the mucosa part which is still enhancing well. This is nothing but submucosal edema, gross edema, and this is muscularis propria is well enhanced. So again this is the that's how you are getting the double donut sign. The layers of the abdominal wall are showing up. You can see this part of the bowel. Let's see, okay, this is also bowel, but why there is nothing like this? Because here the wall is grossly thickened. You can see how much it has enhanced, and in this you can see this is again mucosa, inside air is there, this is submucosa, but here some disparity is there, maybe it opened up. So if the enhancement is not being maintained, so this hypo and hyper enhancement alternating, that is also a feature. Maybe it lost its blood supply completely, so ischemia has settled in. So the reason why it's a bit confusing, you can't always tell is ischemia is, let's say there is vein thrombus. When there is vein thrombus, obviously the contrast is not going out. There is no way, outside door is closed, so the contrast will settle in. So there will be hyperemic. That doesn't mean the bowel is alive. It is so grossly engorged, the arterial supply is not coming, so there is not enough oxygenation. That won't survive, but still it will be hyperemic. So hyperemia alone will not tell it's alive or not. So this is one of the most significant signs that you have to pick. So to conclude, so acute abdomen is an emergency unless proven otherwise. So timely intervention is important to decrease the morbidity and mortality. So the above said warning signs, we have to always try our level best to pick it up. Yeah, it's a challenge. You need multiple attempts. I think I have missed enough. Yeah, it's not easy to pick, but yeah, should always make an attempt and keep reading to improve. Thank you.